Welcome to the first WakeMed Guideline webpage and app, Quick Take. Quick Takes are short videos introducing you to new guidelines. Remember, the Guideline webpage can be found at www.wakemed.org/SPG. The website is mobile-friendly and publicly accessible, so you can look at it at home. If you haven't already, add it to your smartphone's homepage as an app. Today, we're going to be reviewing our new blunt cerebrovascular, or BCVI, screening guideline. Blunt carotid and vertebral artery injuries are collectively referred to as blunt cerebrovascular injuries, again, BCVI. BCVI occurs in approximately 1% of patients with blunt trauma admitted to trauma centers and are most commonly the result of cervical hyperextension or hyperflexion. Rates are 5-fold higher in patients with severe head, face, and or cervical spine injuries. The pathologic insult in most cases is an intimal tear. The exposed subendothelial collagen promotes platelet aggregation and thrombus formation, which may occlude the vessel altogether or embolize to the cerebral circulation, causing a stroke. In some instances, this process develops into a pseudoaneurysm. Early diagnosis and treatment is critical to reducing the risk of stroke and mortality in patients with BCVI. Also, and this is very important, neurologic deficits may not be present. On initial exam, it's up to half of patients develop neurologic symptoms greater than 12 hours after injury. So, how do we diagnose BCVI? We do that with a CTA of the neck. And the screening criteria we're going to use are the Denver criteria, which includes signs and symptoms of BCVI, which are mostly bad things like hemorrhage from the neck, a bruit, and or focal neurologic deficits. Importantly, the risk factors included in the Denver criteria are very broad. And in a center like ours that sees a lot of high-speed MVCs, many of our patients, if not most of our patients, will meet criteria for screening. The first risk factor is the broadest, a high-energy transfer mechanism. This includes high-speed MVCs or a fall from height. The rest are injuries that are associated with BCVI, things like bad face fractures, severe TBI, upper rib fractures, and near-hanging accidents or clothesline type injuries. If the patient meets any of these criteria, they should have a CTA of the neck. At WakeMed, CT scanners, the CT scanners we have here are all greater than 16 slice and therefore meet image quality recommendations. It is also critically important to recognize that CTA of the neck is performed oftentimes in conjunction with CTA of the chest, abdomen, and pelvis, and therefore does not require additional contrast. And because we perform CT scan of the cervical spine on most of our blunt trauma patients anyways, there's also no additional radiation exposure for the patient. Finally, it's important to note that ultrasound or MRI imaging of the neck vessels is not recommended as a screening modality. Now, injuries are graded according to the Denver BCVI grading scale. Grade 1 is a luminal irregularity or dissection involving less than 25% narrowing. Grade 2, dissection or intramural hematoma with greater than 25% narrowing, intraluminal thrombus, or a raised intimal flap. Grade 3 is a pseudoaneurysm. Grade 4, occlusion, and grade 5, transection with free extravasation. And when it comes to treatment, there are 3 mainstays. The first, antithrombotic therapy. This includes heparin, aspirin, Plavix, or a combination of those. Surgery and or stenting. For all blunt cerebrovascular injuries identified on CT scan, the neurointerventional team should be consulted. Finally, blunt cerebrovascular injuries often evolve over time, and they even may resolve. As such, it is recommended to repeat a CTA scan approximately 7 to 10 days following injury. That's it for today's WakeMed Quick Take. You can expect to see Quick Take guideline review videos in your inbox every few weeks. Please take a couple of minutes to watch them. Thank you very much.